Welcome to CardioCast for Friday, November 8th. I'm Dr. Jim Dwyer. In this week's edition, certain metabolic factors in childhood give clues to diabetes susceptibility, and a neutral result in a major heart failure trial may still reveal a benefit in HFpEF. But first, thanks to all of you who've helped us make this podcast better by taking our short listener survey. We encourage those of you who haven't to complete the survey by following the link in the show notes. And now the news. There's plenty known about the relationship between cardiovascular risk factors in adults and cardiovascular disease. But Dr. Terrence Dwyer says there's virtually nothing known about the relationship between those risk factors in childhood and later adult disease. Until now. Speaking at the annual Congress of the European Society of Cardiology, Dr. Dwyer, no relation, of the University of Oxford in England, laid out direct evidence tying childhood risk factors to adult cardiovascular disease. The evidence comes from the International Childhood Cardiovascular Cohort Consortium, or I3C. I3C includes investigators from 7 pioneering prospective child cohort studies, which collectively measured major cardiovascular risk factors in more than 42,000 children beginning in the 1970s. Dr. Dwyer says pooled data from I3C provide the first direct evidence that high serum cholesterol, blood pressure, body mass index, and smoking in childhood are linked to increased risk of hospitalization for acute MI, stroke, and peripheral artery disease in early middle age. Specifically, the analysis showed that each 10% increase above average in serum cholesterol in childhood was associated with a 16% increased risk of hospitalization for a cardiovascular event at a mean age of 49 years. A 2-point rise in BMI was associated with a 20% higher risk. A 10% increase above average in systolic blood pressure in childhood was linked to a 40% increase in risk of a cardiovascular event in later life. And smoking in childhood or adolescence was associated with a 77% higher risk of a cardiovascular event. Dr. Dwyer cautions that the I3C analysis also demonstrates that exposure to cardiovascular risk factors in childhood has an adverse effect above and beyond that seen when the same risk factors are present only in adulthood. For a complete look at the I3C findings, click the link in the podcast notes. A narrower study of childhood risk factors shows that abnormal HDL cholesterol metabolism in children could be a red flag for type 2 diabetes risk later as adults. Researchers at the University of Bristol in England found changes in HDL cholesterol metabolism in children as young as 8 years, decades before the disease's clinical onset. They reported the findings at the annual meeting of the European Association for the Study of Diabetes. The investigators linked genetic risk with metabolomic data collected at 4 time points from more than 4,700 children in a longitudinal parent-child study. One early metabolic feature that stood out was the size of lipid particles at age 8. Among those who would go on to develop type 2 diabetes, there were reductions in the lipid content of HDL cholesterol particle subtypes. By age 16, strong associations remained between lower lipids in HDL cholesterol particle subtypes and type 2 diabetes risk. The researchers say that knowing the early features of type 2 diabetes could help clinicians intervene much sooner to stop progression to the disease. We'll be right back after this message. The primary endpoint of PARAGON-HF was neutral in patients with heart failure with preserved ejection fraction, but that didn't stop some experts from seeing a practice-changing message in its findings. The drug studied in the trial, Sacubitril valsartan, is already approved for treating heart failure with reduced left ventricular ejection fraction. PARAGON-HF evaluated it in nearly 5,000 patients with heart failure with preserved ejection fraction, or HFpEF. The results yielded a relative risk reduction in the study's primary composite endpoint of hospitalizations for heart failure and cardiovascular death by Sacubitril valsartan of 13% with a p-value of 0.059. It was an excruciatingly close near miss for statistical significance, but a clear benefit was seen in a subgroup of HFpEF patients with a modestly reduced left ventricular ejection fraction. These findings seem to convince some experts to soon try using Sacubitril valsartan, also called Entresto, to treat selected patients with HFpEF, driven in a large part by the lack of any other agent clearly proven to benefit the large number of patients with this form of heart failure. Dr. Scott D. Solomon presented the results at the annual Congress of the European Society of Cardiology. He said that HFpEF is a huge unmet need, and data from the PARAGON-HF trial suggests that Sacubitril valsartan may be beneficial in some patients with HFpEF, particularly those with a left ventricular ejection fraction that is not frankly reduced, but less than normal, specifically patients with a left ventricular ejection fraction of 45% to 57%. His suggestion cuts against the standard rules that govern the interpretation of trial results, but met a substantial level of receptivity at the Congress. Dr. Philippe Gabriel-Steg, who had no involvement in the trial, commented that everything in PARAGON-HF points to a substantial potential benefit. I'm not impressed by the p-value that just missed significance. I think this is a very important advance. Dr. Deepak L-Bhatt agreed. He said that the PARAGON-HF results were positive in patients with an ejection fraction of 50%, which is not a normal level. He interpreted the results to mean that the treatment works in patients with an ejection fraction that is lowish, but not at the conventional level of reduced ejection fraction. The key subgroup analysis detailed by Dr. Solomon was the incidence of the primary endpoint by baseline ejection fraction. Among those with an ejection fraction of 57% or less when they entered the study, treatment with Sacubitril valsartan cut the incidence by 22% compared with valsartan alone, a statistically significant difference. On the other hand, patients with a baseline ejection fraction of at least 58% saw no effect on the primary endpoint. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Sarah Freeman, Bruce Jansen, and Mitchell Zoller, and CardioCast Cardiology News and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. And be sure to take our short listener survey. For MDedge, I'm Dr. Jim Dwyer.